Now let's move on to disease-specific applications. Healthy Child has developed disease-specific applications for all three disease areas, such as juvenile idiopathic arthritis, annotate in rheumatology, and a 3D registration tool for neuro-oncology. But here we'll only focus on the suite of applications developed by Siemens and INRIA in the field of cardiology. We shall first explain what went into the development of the heart models, which were all designed to be clinically relevant, and then we'll go into more detail about how they're being used in relation to the blue baby syndrome. Healthy Child's heart models is a disease modeling area where Healthy Child has worked particularly well within the virtual physiological human approach. Tommaso Manzi from INRIA will tell us just how the virtual physiological human field brings computational modeling work into the clinical routine.
Basically, in a clinical routine, you have a patient. And from that patient, you acquire signals, medical images, clinical informations, and so on. And in the other side of the research, you have people that are trying to build some computational model of the human body, computational model of the geometry, anatomy, physics, and so on. And the idea of the VPH is to bring the two worlds together. Because if you can use the computational models to improve the diagnosis to help understand what you see in the medical images, for instance. But you can also use the images to personalize your models and then improve the prevention and the therapy of a given patient by improving the diagnostic, the prediction, how will be the heart after a surgery, and also the planning, when is it the right time for surgery.
How did Healthy Child develop the anatomical model of the pulmonary trunk? As you can see from these two slides, there are a series of distinct steps that are required to develop the Healthy Child pulmonary trunk model. 4 steps were designed to utilize machine learning techniques. First, we collected the computer tomography and magnetic resonance imaging data from the patients. Second, the data was annotated to develop an average model. As first step, the characteristics points were found or suggested, which in turn became landmarks. And fourth, the boundary conditions were identified for the heart. Let's now listen to Martin Huber, who led Siemens' efforts to explain this process in more detail.
Again, I go into a little bit more detail with regards to how we actually do this. And the basic of our tools is always that we try to utilize learning technologies. So what we need, and where also the clinicians come into play, we need ground truth. We need annotated data sets. So for the computer to start learning how a heart looks, the computer needs a lot of examples. And typically for commercial products, we say we would need 200, 300, 400 of each organ. The more, the better. In Healthy Child, we had to do, in some cases, with 50, 60, 70s, which is also on the limit of the method. So we have the clinicians, or typically it's poor medical students, who have to do this very tedious work, and the clinicians afterwards are going to look over it and really sign it off. We have these annotations manually, a database of it, and the first thing you can get is basically an average model. If you have 50, 100, 200, let's say, livers, you get an average model by just averaging over the measures. And then you also, at the same time, you get the variation. So you have a kind of statistical model of the heart, all the variation that can be seen, and the average. And this is the basis of the detection phase. When you get new data, you can start in a series of processes. You can start looking for characteristic points. We call them landmarks, and then you can go for whole organs and find the boundaries, etc. There's a series of steps that comes on the next slide. And then you basically fit in the best your model allows, given the variance that you allow for the model. Sometimes it's beneficial for some of the organs if after this step is done, you do an additional smoothing step where you only look at the boundaries and try to adjust as good as you can to the clinical data, to the images. Okay, this is what I showed yesterday. So here, why do we do this? The reason is, again, because morphology is really the most important thing here to determine if a certain procedure can be done or not. And now here in more detail, what's going on. So the first thing which we detect is 4 landmarks in this case. Why landmark detection? This is much faster. This is characteristic points. It can be done very fast and very accurately. And typically this is points that clinicians help us because they are characteristic. And in this case it was Andrew Taylor who suggested these 4, and they work pretty well. This goes pretty fast, and when you have the center line in between, in this case, this was specific to the pulmonary trunk. In our cases, we don't do this step, but here it was beneficial to then create a center line between the points. And in the final step, we detect the boundary